It's me again, and we're going further down the hand into metacarpal and phalanx fractures. If you don't already know, I'm a hand surgeon, and we're that much closer to being done. Maybe we'll see the sun. No, it's already gone, huh? It's already fading. All right. Common fractures, there's tons of these that happen every year. Phalanx more than metacarpal. Most of the phalanx ones are happening because a lot of fingertip crush injuries that occur. So distal phalanx makes the bulk of all the lion's share there. Once again, same thing as we talked about before. We're trying to restore normal function to the finger, the restoration of bony anatomy. Early motion is required to have if inherent stability of the fracture with a splint or with secure fixation. Early motions can prevent our stiffness of both our flexor and extensor mechanisms. This also can prevent joint contracture. Mobilization, mobilization beyond 4 weeks is a cause of stiffness. And we know in phalanx fractures that if you immobilize a phalanx fracture, beyond 3 weeks, there is permanent loss of motion in the finger. 3 weeks. So same principles that for every fracture, anatomic, near anatomic reduction, stability, atraumatic technique. There's not a lot of wiggle room here, and especially in a phalanx and a finger. There's, we talked about talus earlier and calcaneus and in our femoral shaft. There's a lot of wiggle room in the femoral shaft on our hip fractures and things like that. But we're getting to fix the finger fracture. There's only so many screws you can put in a finger until you can't put a screw in a finger anymore. Pain control, and again, early active digital motion. So our fracture configurations can be transverse, which can sometimes be stable. Spiral, oblique, and comminuted fractures are more unstable. A lot of that depends upon the integrity of the periosteal sleeve. So if you have a fracture that was displaced at the outset and it's reduced, especially a spiral fracture, if you can pull on that fracture all the time, but as soon as you let go of pulling on that fracture, on that displaced spiral fracture, that fracture just is going to shorten again because the periosteal sleeve is torn. But you'll see occasional patient comes in where there's a spiral fracture, but it's non-displaced. So the periosteal sleeve is going to be intact, and that person could be treated with buddy tape sometimes and early range of motion and a lot of close follow-up to make sure that your plan is working and the fracture is not shifting on them. Usually it doesn't. So fracture stability is a combination of the forces against our finger, so the muscles that are and the tendons that are pulling on it, and then the external forces, they combine for displacement. So this is very typical of a fracture that we see, usually our fifth metacarpal boxer fracture, or this is more along the lines of a shaft fracture, and we get our apex dorsal angulation because of the unbalanced pull of our intrinsic tendons in the hand, the interossei. They're flexing down a distal fragment. Now, we know that our fifth metacarpal can take a lot of angulation. That's because the CMC joint is so mobile. Our index finger, middle finger can't accept that much angulation because the CMC joints are more unstable, more stable. There's not a lot of motion there, and they're less forgiving. So typical deformity that you're going to see in somebody who has I guess as we call it, a malunion. He never had surgery for it, and he's comfortable with it. But when he makes a fist, you don't see the prominent knuckle. Deformity is there, but it's not so bad. But when he extends his finger, that's a pretty good amount of deformity, but he doesn't care. This is what patients do not like, is rotational abnormality. Okay, this is never going to be tolerated. You can tolerate a lot of dorsal angulation and live with it, even in the index finger. But scissoring like this, there's just no way this young lady is going to tolerate scissoring like that. So more than 5 degrees off, causes more scissoring. The more further out the finger you are with rotational abnormality, the less degrees of rotation are necessary to cause a more clinical scissoring. Translate, metacarpal fracture can tolerate more rotation than a phalanx fracture. All right. Fractures shorten in the metacarpal. They shorten more on the border digits, so our index and our little are more likely to shorten than our middle and our ring because of the intermetacarpal ligament that's keeping the fingers out straight. Why do we care about shortening? Because the more shortening we have, the more lag that comes because of the extension mechanism. So 7 degrees of shortening, 7 degrees of extensional lag for every 2 millimeters of shortening in a metacarpal fracture. Sometimes that shortening is able to be overcome with the natural hyperextension. Then the patient looks like they get pseudo-clawing, but when it's short, they're going to get a little bit of lag. Phalanx fractures, okay, they're going to go, usually they're at in this area here or more towards the base. They're apex volar now because they're getting pulled by the FDS tendons or pulling down this way as well as the central slip. The book says 25 degrees could be tolerated. In my experience, 25 degrees at a base of proximal phalanx fracture is too much. I don't know a number to say that this is the perfect number to where you operate on them, but 25 degrees, they usually get pseudo-clawing and they don't get great flexion back afterwards. So I would be more aggressive in trying to reduce that better or trying to pin it. Proximal phalanx is poorly compensated for shortening. So for every millimeter of shortening, now we're getting 12-degree of lag. So as we get out the finger, the more the shortening becomes more symptomatic. Any rotational abnormality that's present becomes more symptomatic and problematic. Middle phalanx, where it goes, it kind of depends upon where the fracture is because it has both the central slip acting one way and the flexor tendons on the other side acting the other way. Base of proximal phalanx fractures, again, if we're fixing them with surgery, it's usually done with the way I do it is percutaneous K-wires placed off the base of the proximal phalanx through the shaft, and I try to get them out as far out as I can. So I try to get it kind of in the canal to go out almost close to the articular surface. Sometimes it's a hard angle to get, and if I get it in reasonable and it's just not going out as far as I want it to go out, I'm leaving it because trying to adjust it sometimes can be really painful, and wire after wire after wire, it's challenging. What you can do is, as a little tip, is take a 14-gauge needle if your hospital has 14-gauge needles, and you can take a 14-gauge and you can use that as a drill guide for most 4 or 5 K-wires. So instead of kind of messing around with the wire and X-ray, you can take your 14-gauge needle, you can kind of feel with the 14, the dorsal and volar of the proximal phalanx, get your kind of good spot to where you're starting, get that X-ray, and then just use that as your guide to shoot it up. It can save a lot of time. Out in the shaft, you got to make sure that the fracture is compressed. So there was one kid I took care of years ago who had more of a shaft fracture than a base fracture, and I pinned him, and probably was a little bit gapped. And when I pulled the pins out, he re-angulated within probably a couple of days. Never looks good. With plates, there's more dissection and there's more scarring. We try to keep the plates off the dorsal side of the finger, but sometimes you have to. But if you can get them lateral, it's a nicer place to put them. And back to K-wires. Those K-wires are in for 3 weeks, usually 4 weeks, maybe in a shaft fracture, but in the base in that metaphysis fracture of the proximal phalanx, 3 weeks, wires out, and they have to start range of motion. Otherwise, there will be permanent stiffness. There's not a lot of forgiveness. Extensor tendon wants to scar down to the bone. Flexor tendons want to scar down in the sheath, especially if you've been passing the K-wire 8 billion times, and it's off and off and off and off, and you're poking it through the extensor tendon, and you're poking into flexor tendons. Long spiral fractures, the key here is to know that it's more than twice the length of the bone, or the fracture length is more than twice the diameter of the bone. And that means that the fracture can be fixed just with screws. It doesn't need a neutralization plate. So sometimes you can do them closed, sometimes you have to do them open. If you're doing them closed, you need fluoroscopy, obviously. You can have a pointed reduction forceps, like any bone clamp that's out there. Some of them are fancy, and they'll actually have a place where you can put a K-wire with the clamp. So there's a K-wire, like a little K-wire guide attached to the clamp. You see it in all the journals. You can place them parallel to or you can place the K-wires perpendicular to the fracture, like standard compression technique, or you can place them just perpendicular to the bone itself. It doesn't have to be standard type of AO compression technique. It's a finger, it's not an ankle. If you're going to change them, you can change them sometimes for screws. So basically what you do is you drill your K-wire. You can take 2 K-wires in, then you can take 1 K-wire out, put a screw over that percutaneously, and then do the same with the other K-wire. So 1 drill bit is the same basically almost as a 4 or 5 K-wire. So if you have a 4 or 5 K-wire in place, you don't necessarily have to take drill it again now with a 1 drill bit from your modular handset. You could just use the K-wire for your drill guide because it's close enough. And you don't have to over drill the outer cortex if you don't want to, because again, it's a finger, it's not an ankle. You don't need standard lag compression techniques for it all. So this is an example of one here, just a little short on the, a little short up there, just a couple of millimeters short, and again, pulled on and fixed with percutaneous screws. If you're going to open it up and fix it, you come through the side. I try to come through the side as much as I can because this way I'm not violating the extensor tendon. So if we come in dorsal, sometimes we split the extensor tendon, and then that extensor tendon tries to scar down to the plate and to the bone and cause a problem. So if we can come off the side, it's always nice. But sometimes it's harder to get your reduction. You're not seeing things as easily and as clearly as you are here. I think these fractures are more problematic in the phalanx than they are in the middle phalanx. Middle phalanx is a little bit more forgiving in terms of your exposure too as well. But out here, it can be tough. If you're, usually there can be a nice layer of periosteum, and if you can cover your plate with that periosteal tissues, make it like a layer, and close the periosteum over the bone again on top of the plate, and you can then theoretically what you're hoping is that your tendon is going to glide on that periosteal tissues and not glide on your plate, and you're going to get less adhesions. But if I'm operating over here, I'm always telling a patient that there's a good chance that we have to go back and take hardware out and do tenolysis and all that stuff. So when we do a lateral incision, again, coming off the side here now, we are going to run into our lateral band, and as it becomes part of our extensor mechanism, and this has to be dealt with. So you could retract it out of the way, like this is just lifting it up here, or actually you can excise a portion of it too as well without any harm. So you can take this part of it out so it's not impinging upon your plate that's over there. That's okay to do that. That's no problem. And this is just an example of that. Actually, this is that malunion patient, but this is where her fracture site is here. This is our exposure. It's pretty good exposure of the area, and we're in the lateral band part of the tendon mechanism is coming up this way here. We're just going to excise that out, extensor tendon, retract it off the top. Want to get early range of motion to the finger. The index finger is what on this patient was what had surgery. Pretty good extension. You can see her flexion's not complete. You know, she's pretty good, but she doesn't come down all the way. You want to start early motion. I'll see the person. If I fix the finger and I'm plating it or putting screws in it, 2 days later I have them in with the therapist, getting a splint made and start early range of motion to the fingers. So short oblique long oblique is more than twice the diameter of the bone. So short oblique is less than twice the diameter of the bone. That can't be fixed with just screws. There's only going to get one screw, and it's not going to be enough. You need neutralization, so you're going to need a plate, or you're going to fix it with K-wires. Unicondylar fractures in the proximal phalanx can be disasters. This is the one fracture where if it's non-displaced to start out with, you got to keep a close eye on it, because this is the one that's going to displace during even if you have the person immobilized and not moving, this is the one that can displace even inside a splint. So some of these have actually pinned before they ever got a chance to displace. They come in, it's a non-displaced fracture, and I'll tell them, we could take you to the operating room now, don't have to do anything in terms of reduction, just put 2 wires in your finger, that'll hold the fracture in place, it'll prevent it from potentially slipping out of place, or we can keep a close eye on it, and I've had patients go either way with that. Displaced fractures, if you get them early enough, you can do a closed reduction. Otherwise, it's an open reduction. 2 ways to get at it. You can go mid-axial, right? And like we kind of described before, it's easier to put your screws in if you have the mid-axial approach. So if you're going from the side of the finger, it's easier to get your screws in than if you're coming off the top. But if you're coming off the top, you're going between the central slip and the lateral band. But now you have a little bit harder time to be able to get your fixation in, because your fixation usually for those is going to be coming off the condyle of the proximal phalanx, just at the articular surface right by the ligaments. And you got to remember that you don't want to take down that ligament, because that's your stability for your joint. It's also the blood flow to the proximal phalanx, that articular surface. And if get AVN of that articular surface, there's not much room for you to go with. And again, we're talking before about if you put a screw in and it's the wrong screw and it's not in the right plane, there's no second chance. If you implode the fragment, that's it. The fragment is gone. So you have more than one chance in the femur, but you don't have really more than one chance, in my opinion, in a proximal phalanx. Recess the screw all the way. You can get 2 screws sometimes, but if you can't get 2 screws, you get 1 screw and 1 K-wire, or even sometimes just 2 K-wires. So here's one where you can see the deviation of the finger, unicondylar fracture, and fixed with 1 screw and 1 wire. You know, good position there, dead center in the kind of in the finger itself. Wire comes out after about 3 weeks. The screw we try to keep forever. So if it doesn't bother them, we leave it alone. As you start to get into worse proximal phalanx fractures, bicondylar fractures, now we're talking about plating them, sometimes blade plates to reduce the joint and then fix the joint to the shaft. And obviously, that's a worse fracture. You start seeing blade plates in fingers, and you start talking about more stiffness. And you can see here with the bulk of the plate that's present on the side of the finger, there's a good chance that plate's going to have to come out, and the person's going to need a secondary surgery for tenolysis as well as hardware removal. It's a nice little technique if you come across it. If there's bad comminution of the middle phalanx, right? So you have shaft of the middle phalanx, volar portion of the middle phalanx, dorsal portion of the middle phalanx. This is pretty hard to fix with screws or wires or anything. So we do dynamic traction. There's ones that are made by companies. I think Compass has one and all these other ones. But this is just a simple K-wire technique where, hold on. That's what it looks like. I had to invent it, and described pretty well by the late Joe Slade. 1 pin goes through the center rotation of the proximal phalanx at the joint. Second K-wire goes further out the finger, kind of just in at the same portion of the middle phalanx. And then this one's here is just kind of above the fracture as the third K-wire. You bend your wires, you loop them back and forth, you get some dental rubber bands, and those dental rubber bands pull traction on the finger. And this other K-wire can be helpful in reducing the fracture. And then you get the person starts moving the finger with the rubber bands on. They're about 3-4 weeks that's on, and then it's removed, and then they start range of motion. So you're not looking for an anatomic reduction of the joint. You're looking for congruence. So you're looking for the proximal phalanx articular surface to be congruent with the articular surface of the middle phalanx. It's not an anatomic reduction by any means. It's just a dynamic traction. Metacarpal, moving a little further down now, metacarpal fractures, metacarpal head fractures, I don't see these too often, but usually they're going to be fixed with some sort of buried screw, like a Accutrax or Herbert or whatever screw you want to use. The Brewerton view is the x-ray to get to look for those fractures, and CAT scan can be utilized as well. So there's just a screw in there. Complications, AVN, it's a dead piece of bone, there's no soft tissue attachment to the articular piece of bone, and stiffness. If there's a lot of comminution, you're going to plate it. But if you're going out that far with fixation, if you're in the joint with fixation, it's early range of motion again, and telling the patient once again that you're going to have a high chance to need another operation like a capsulectomy to go in there and get your finger moving again, because that's all going to try to scar down. Closed transverse fractures of the metacarpals, you reduce them, you splint them. Again, we talked about saying that the ring finger and little finger have more CMC motion, and therefore they're allowed to tolerate more deformity. Metacarpal neck fracture, I'm going to keep splinted for 3 weeks and then come out and start motion. Metacarpal shaft fracture, I'm going to splint for 4 weeks. It just takes longer for the shaft to heal. Pinning, I've done this technique where we're just, I usually put another wire in here though too as well, where we're just taking our fifth and pinning it to the fourth. It's kind of like, think of it like an external fixator where this is your bar, but I will put another wire in here. This is just well, it's hard to see, but angled fourth metacarpal shaft, reduced, looks good. This is back before I was casting them. Now I'm casting them, which can be sometimes annoying to put on, but I cast those patients. It failed, it angulated again, and this is back when I was doing this type of technique. This was poorly tolerated by people, right? So these pins up here. If I'm going to pin a metacarpal shaft fracture now, I'll make a hole back here in the base. It can be made with a drill, it can be made with an awl. I'll take a K-wire, a 6'2" K-wire. I'll clip the end of the 6'2" K-wire off to get rid of the sharp tip of it, and then I'll just give a little kind of bend to it, gentle bend to the wire, and then putting it on something, whether it's a chuck or a needle driver or something like that. Then I'll use that as an intermedullary rod up the finger. There are commercial devices that do that same thing, where just has a trocar that goes in, and then you kind of deploy a little rod up there too as well. But the 6.2 K-wire still works. There's an example of those. The problem with these is the hardware has to come out. So this is in my hands, I put that in. That means I'm coming back to the operating room because I'm burying the wire so the person can move their fingers. So I'm burying it well so that it doesn't bother them, doesn't irritate them. But then I can't feel it in the office to make a skin cut, find it, and pull it out. So it's a trip back to the operating room to do it under fluoroscopy control because I can't do it in the office. But this is the technique I'm pretty much using now. Metacarpal fractures, transverse ones, open reduction is still a nice way to go. Plate fixation, stable fixation, early range of motion. And so this is kind of our incision site. If I'm fixing the fourth or the fifth, I'll make an incision over here. If I'm fixing the index or the middle, I'm going to make my incision over here. I don't make it directly over each individual metacarpal. I'll make it in between the two of them in the intermetacarpal space. Got to watch out for your sensory nerves. So on the radial side, there is a sensory branch of the radial nerve that's right in our way. That's another one of those annoying little skin nerves that when it gets irritated and aggravated, loves to cause RSD or complex regional pain syndrome and a lot of annoyance to patients. And this is the sensory branch of the ulnar nerve, so beware of those nerves in the area. These are extensor tendons. We're not taking down the peritoneum around the tendon. We don't want to kind of take all that soft tissue off the tendon. We're not exposing the tendon. We're just moving the tendon over and getting down to the periosteum right below it. If there's a junctura that's blocking my ability to retract well enough, I'll clip the junctura, and then later on at the end of the operation, we'll repair that back. So this is just an example of what it looks like when we're closing it. That we're closing the periosteal tissues over the plate itself, so we don't see the hardware. We don't want to see the hardware when we're done with the operation. We want to keep it covered so the tendons can slide right over it. Metacarpal shaft fractures are going to do real well with motion because there's going to be great soft tissue coverage over it. Where you're going to get into problems with plates for metacarpal fractures are going to be when they're further out the finger and you're getting into the metacarpal neck fracture. Those are the challenging ones. If you see the articular surface or you see the capsule during the dissection, then those are ones that in my hands anyway, they are more prone to stiffness. They're more prone to needing a secondary surgery for plate removal, tenolysis, and capsulectomy to try to get their motion back because that plate just, well, the capsule is just going to scar right down to the plate. It's going to impede MP flexion. They're going to get an extrinsic tightness, and you need to go back there. Otherwise, they're making a fist like that, not with their knuckle all the way down, even though you have them in therapy from the get-go. So this is an example of a plate that's on. Usually it's a 2.0 plate that I'm using. Usually put it in the compressive mode. They do have locking plates now available for these things. Those implants are much thicker than the regular plates. There's a lot of different varieties now they have with screws coming in from multiple angles that you can get 4 or 5 screws in the distal fragment and 4 or 5 screws in the proximal fragment because they're coming in from all over the place. But that's just a standard technique that's going to be fine. You do when you're putting plates in, you want to watch for rotation because you can plate them rotated. And if you plate them rotated, you're going to be having that person in the office like we saw before who's scissoring, and now the fracture didn't do it, but you did it because they weren't rotated before. So with every screw that goes in, I check tenodesis. We extend the wrist in the operating room, let the fingers fall down and see where the fingers go, make sure those fingers aren't rotating, not scissoring one under the other. What can happen is sometimes with the little finger, there can be some natural rotation that's there. So if that's the case where it looks great in the body, but when I extend the wrist back, there's this little rotation of the little finger going on, I'll have somebody else out of the field do the opposite arm just to see what the rotation is of the opposite arm while with tenodesis, because invariably, usually it's very similar. Long oblique is the same thing, 2 to 3 times diameter of the bone, just translated to the metacarpal. Closed reduction is not going to happen. You can pull on that all day long. You're either going to accept the shortening that's there, or you're going to fix it. And what's good here is that you can just put screws in these type of fractures. So long oblique, short fracture, you can see it's a border digit, so it's shortened a pretty good amount from where it's supposed to be. This piece right here is supposed to be all the way over there. So we're going to have a pretty good amount of shortening, pretty good amount of extension of leg. And again, just fixed with multiple screws. These are 2/0 screws. You want to make sure that your screw diameter is not, want to be away from the edge of the bone at least 1 screw diameter before you put that screw in and drill it, because otherwise what you'll do is you'll crack the surface on the opposite side, and now your screw is going to be useless. You've got to countersink the screws so the prominent screw head's not going to be there, so you can close your periosteal tissues over it. So this is where I will use a countersink most of the time. With most of the implants that are out there now for the hand, it comes in multiple different sizes, so you're not just using one kind of. Multiple size screws are available for you, all the way from 1/1 to 2/4 in the same set. So we use a combination of different size screws depending on what the fracture gives you, and come in from different angles. While you're reducing it, what you want to make sure is where you want to kind of get a handle on what that fracture looks like, because it's not just, these screws can't just go in straight. It's a spiral fracture. So you want to make sure that when you're putting that leg screw in, that you're getting the other side in an appropriate fashion. So you really got to kind of take a good look at your fracture while you're reducing it and really kind of get a handle on how you're going to put your screws in. Short oblique is more along the lines of the same thing. It's more like an ankle fracture. You're going to put your leg screw in, and then you're going to put your plate on to neutralize it as well. And that's just an example of one there. This plate out here, this far out the knuckle, more than likely is going to have to come out. And again, comminuted, again, far out the finger. This is bridge plating here. We're just putting our fixation distally in the head. This is a blade plate. So distally in the head, pulling on the finger, getting the length back, and just putting our screws in the shaft. You can see how it heals kind of with a secondary bone healing with callus. And again, when the fracture goes this far out, you can't see it too well, but this is the joint. That plate and screws is going to have to come out. Reverse Bennett's is just right, there's our ligaments are attached there. Articular surface is off there. And those are going to be those are going to be pinned with 5th to 4th and 5th to the hamate. Sometimes it can be associated with a hamate fracture along with it. If it is associated with the hamate fracture, which is more of a dorsal shear than this type of thing, you want to fix the hamate fracture. Don't try to pin it. I've done that. It doesn't work out so great. So you just got to fix the hamate with screws. This example of just a 4th metacarpal base or 4th metacarpal shaft, and then a 5th CMC dislocation, which was just pinned. That's it.